The next 30 minutes, I'm going to kind of do a speed dating aspect of complementary and integrative therapies in cancer care. I have a lot of disdain for the word alternative because when I got certified in integrative medicine, I was very concerned that my colleagues would think that integrative medicine had something to do with giving patients an alternative to what we do in Western medicine. But on the contrary, there's nothing alternative about integrative medicine. It's really about helping our patients navigate a really difficult journey through cancer care where we have the opportunity as their providers that they trust to help them to mitigate side effects, to improve their quality of life, and to come out the other side of cancer with an enhanced aspect of survivorship, which was something that I was never taught during my training. These are the companies that I work with. Several are very avant-garde new technologies that I hope that you will know and hear of in the next 5 to 10 years because I think we're going to make a difference in how patients come through cancer care. Okay, this is my old farmhouse in Bucks County. We were doing a redo in my son's bathroom, and when we peeled off the wallpaper, I was appalled to see that, my child who had been suffering from allergies and all this stuff in his room, little did I know that the mold that was hiding behind the wallpaper in our 300-year-old historic farmhouse. And so I did what every self-respecting mom would do. I went and got the Clorox, and it's amazing what Clorox can do for mold. And I'm thinking, wow, that mold's kind of like the cancer that our patients show up with, which can be hiding deep behind the recesses of the wallpaper. And if all I do is use that Clorox in that bathroom and put anything else on that wall, I'm not going to change the fact that that mold can come back. So you have to learn how to open the windows, change the ventilation, change the light source. And to me, this is the soil and the seed theory about cancer care that we all need to really understand. Cancer cells are the seeds that propagate in soil that is fertile for them to grow. So if we only address the seed, which is the cancer, with our surgery, chemo, and radiation, and we don't address the soil that those cancer cells like to grow in, that we're not really doing the most for our patients. So that's what the next 30 minutes is going to be about, because we don't want this to come back. In integrative oncology, it's really been a beautiful journey for me because we constantly remind ourselves as clinicians the important role that we play, not just for the patients, but for the patients' families. Because a diagnosis of cancer literally cuts somebody off at their knees, it guts them, and they have an instant existential crisis with what does their life really mean, how long do they have, who's going to take care of their family if they're not here. So take a minute to, really sit with yourself and know the important role that you play in this process. Integrative oncology is really evidence-based medicine in utilizing mind, body, spirit medicine, using other interventions to help mitigate side effects. And I like to see it used alongside conventional cancer care. I was asked in a question by one of the people in the putting on the conference, what do we need to know about this? Your patients are seeking integrative solutions to their side effects, whether you know it or not. So either you choose to partner with your patient and let them be honest with you, or they may seek out interventions that you don't know about. And I'm going to end with that slide with one of my patients. So integrative oncology really looks at all the different terrains of the body, looking at epigenetics, looking at immunity, hormones, environment, toxins that we have in our environment, looking at our gut microbiome, and one of the big ones is inflammation. Several years ago, one of our colleagues from Memorial Sloan Kettering said that, obesity is replacing tobacco Cliff Hudis said obesity has replaced tobacco as our #1 health risk factor because that level of inflammation can set off so many other cascades in our body. The Society of Integrative Oncology looks at survivorship as a key component. And almost 80% of my breast cancer patients are looking for things to help them along the way in their journey. So what they did was they took all of the integrative therapies and they put them into different grades. And I'm going to go quickly through the grades of what they talk about. And I call the grade A recommendations low-hanging fruit because there's no one in this room that is going to have anything bad to say about meditation, relaxation, yoga. But these are these are the studies that have been done that show that it improves the quality of life of our patients. So these are the easy ones. Grade B recommendations: stress reduction, music therapy, massage. These are ones that have no harm, probably have benefit, but there's not as much Western medical prospective randomized data to support. Grade C are the ones that have shown benefit, but it's really what we call shared decision making, because we know ginseng has a lot of positive effects. I'm going to go into that later. Acupuncture, diindolylmethane for patients that have hot flashes on their aromatase inhibitors. And then there's grade H, which is harm. And the one integrative modality, which acetyl-L-carnitine was once really pushed for cardioprotection with chemotherapy, but we know that it increases and worsens the neuropathy that comes with Taxol. So grade H harm, you got to cross acetyl-L-carnitine off the list. My colleague Jay Harness, who's the past president of the American Society of Breast Surgeons, since he is retired from surgery, has really taken on the field of exercise oncology. And it's really funny because when I spoke at the American Society of Breast Surgeons in 2004 about integrative medicine and how we needed to bring it in, everybody kind of thought I was a little bit off the reservation. I thought I was in a very strong branch. Jay now has said, you know, I wish I was paying attention back in 2004, because he feels like he's kind of missed that boat. But I'm like, Jay, it's only 20 years late. I mean, we're going to get there. And the more we work together to bring this information to our patients, the better off we're going to be. So it's an adjunctive approach. The results in the data for depression, anxiety, quality of life, physical function, and risk reduction. And so we have very, very strong post-MI, post-cardiac surgery exercise programs for our patients. But to date, insurance is not covering exercise for our cancer patients, which to me is ludicrous. And it's one of the things that our instructors for our course we're giving next week for young breast surgical oncologists, she said, you know, could you get Jay on that bus to get to Washington, to get to the lobbyist, so that we can get exercise covered for post-cancer patients? And I said, I'm going to work on it. So when you do a systematic review, we know that the physical activity needs to be a mainstay in our approach to management for depression, anxiety, and the psychological stress that comes with cancer. And because cancer is a chronic disease, and if all we do is treat the seed and we don't treat the soil and change the soil of our bodies, we can have people set up for yet another malignancy or for a recurrence. This was just published hot off the press September 1st. Excellent study, 173 women, stage 1 to 3 breast cancer. 86 women got usual care, and 87 women got exercise, nutrition, and counseling about the importance of it, and then the adherence to it. In the intervention group, there was a higher pathologic complete response rate in the ER-positive, HER2-negative, triple-negative breast cancer patients undergoing neoadjuvant chemotherapy, 53% versus 28%. You show me a new drug on the market that gives us that kind of a shift in results, and you know, you would be buying stock in that company. So getting our patients involved in an exercise program is incredibly important. This is a study that came out of the Netherlands looking at physical activity in adolescents who've had childhood cancers. And it's unfortunate that in this study, when they looked at the physical activity versus high sedentary activity, these young cancer survivors were not encouraged to have increased physical activity. So therefore, we're doing nothing to impact the soil that their cancer seeds grew in. In this clinical trial that was published in the British Journal of Sports Medicine in 2023, showed that 10 minutes of exercise alone mobilized leukocytes. Imagine if 10 minutes, what 10 minutes did, and it's intensity related and time and dose related. Imagine if patients exercised for 30 minutes. And this compounded with the prior study on the breast cancer patients looking at usual care versus intervention with exercise and nutrition. You know, we have the opportunity as our patients' guides to give them kind of a little push. And one of the things that I talk to all my patients about at their initial cancer diagnosis is the importance of the modifiable risk factors. You know, I can give them the prescription for their surgery, chemo, and radiation, but then I have a column of, I call it my opportunities for improvement. Sometimes people are too short for their weight. Got two choices there. I don't know many people can grow. Sometimes they're not exercising enough, sometimes they're drinking too much alcohol, and sometimes they're under too much stress. But this shows how much exercise has come into the forefront, because in 2017 we had 556 prospective randomized trials on exercise and oncology compared to like 3 trials back in 1990. So this is an emerging field. It is going to be probably one of the most important fields in oncology because our bodies crave movement. So either we move it or lose it. The impact of exercise, quality of life, 58% improvement, flexibility, positive attitude. We also know that it decreases healthcare costs and expenditures. So again, now exercise is becoming the low-hanging fruit, and it's what I moved up to the top of this lecture, because I think that we all need to kind of adopt the new guard of where we're going in oncology. So ASCO now has new guidelines for exercise. The NAPBC standards are going to ask centers to document the policies for exercise. The problem is insurance doesn't cover this. And this is something that we, as the physicians that are providing the care for our patients, you can go and walk outside. It's free, it's cheap. Getting our patients involved in programs combined with movement and strength training are going to be the mainstays. Cancer prevention lifestyle. This to me was a really important study. It looked at 7 lifestyle factors that were looked at between 2005 and 2010. It was a prospective observational cohort. And the higher the scores indicated higher lifestyle choices. And what we know from this study is out of these 1,340 women, there was a reduction in recurrence and a huge reduction in mortality, 58%, for the ones that had the highest index of lifestyle. So what we know about this is lifestyle behaviors are not just one. You can't be smoking 2 packs of cigarettes a day and run your 4 miles and think that it's an equivalent, you don't cancel the other one out. But it's a cumulative effect of exercise and sleep and stress reduction and getting rid of lifestyle behaviors that impact the risk of recurrence. So it's the cumulative effect, and this study showed a really very nice cohort of patients who significantly benefited from changing their lifestyle. And that's why I call it lifestyle opportunities for improvement, because it goes over a whole lot better than telling somebody that they're doing something wrong. So which exercise approaches work best? 3 different studies, a meta-analysis, and then going back to 2014. All of the studies have a combination of movement, so some type of cardio, but strength training was included in all of these. And as we build muscle, we burn fat. And as we build muscle, we are also increasing our bone density and helping to avoid other complications. But all of them across the board, the combination of strength training and physical activity decreases cancer-related fatigue. It's a big deal. A lot of people continue to have fatigue. And years ago, I had patients that would stop exercising when they got diagnosed with cancer and wondered why they started having more side effects. As soon as I got them back into the gym, their side effects went away and they were cruising through. We are what we eat. Kind of very true. It's the broken record that keeps playing. Why is there confusion for our patients? Well, Time Magazine seemed to be a little confused over the last 20 years, because what they've done is every time some new fad diet or some new fad something comes out, it's on the front cover and everybody gets all excited and they want to get involved. Our bodies crave good nutrients. Our bodies crave movement. Our DNA was programmed to be eating more of a plant-based diet. And the confusion comes from the fact that it depends what the diet du jour is. And what we have to do is really kind of get back to the basics. And whenever you see the word sugar and fat-free, it is a bit of a storm, because all of it is from marketing. How many times, low-fat diet, and then you go to Atkins, which is, high-fat diet, and then you look at the ingredients and, fructose, high fructose corn syrup is the first ingredient. Clearly not a product you want to be feeding your kids. You look at the back of a box of Pop-Tarts, and there's 12 words on there that your grandmother could not pronounce, whether they were given the dictionary and the pronunciation, because these are things that are not real. So this is not not a difficult scenario here. One way is inflammatory, and we're feeding disease. The other one is anti-inflammatory, and we're actually helping our bodies to detoxify. So the impact of lifestyle, unfortunately, the standard American diet, it is sad, because what it's doing is it's increasing our inflammation. Sedentary lifestyles are increasing our inflammation. We have increased stress. People, it's a lot easier for me to get up and go out and exercise when I'm not stressed and when I'm feeling really good about myself. It's not so easy if you had that second glass of wine after dinner and you wake up in the morning and you're like, oh, why did I do that? Going to exercise is going to make you feel better. But the impact of lifestyle, a negative lifestyle negatively impacts our risk of cancer. A positive lifestyle with exercise and movement and decreasing stress can actually lead to decreased estrogen production. It can lead to decreased inflammation, improved insulin function, decreased insulin resistance, and back to an area of risk recurrence. And this is where that study that just got published September 1st is huge, because it's showing us that in patients that had cancer, got the exact same neoadjuvant chemo, that were estrogen receptor positive, HER2 negative, or triple negative, in that patient population, there was almost a 50% more improvement in complete pathologic response. So it's kind of like having an in vitro study within human beings. I love the study on intermittent fasting, because it really showed a decrease in hemoglobin A1C. If our patients intermittently fast for more than 14 hours, and the thing with this intermittent fasting, if you don't shift it back and forth, if someone starts intermittent fasting 14 hours a day, and they do that every day, your body's gonna get used to it. So it's really about playing the game, where one day might be 12 hours, one day might be 16 hours. But intermittent fasting is a wonderful way to help your patients to deal with their hemoglobin A1C. Nobody ever died from not eating breakfast in the morning, just saying. And breaking the fast means if you have coffee in the morning and you put cream in there, you broke the fast. If you have coffee or tea or water, anything with carbohydrate, protein, glucose is going to break the fast. So, this is very, very true of today's alcohol consumption, what constitutes a drink. And I gave a talk similar to this out in Napa a few months ago, which is really hard to give this talk in Napa, because everybody knew where I was the night before with my glass of red wine. But it's 90-10. 90% of the time I behave and I'm good. 10% I'm living my life. We know statistically that we should have 1 drink or less a day as a woman, and for men 2 drinks or less. Alcohol is, it gets metabolized very quickly into sugar. And we also know that drinking alcohol before the birth of our first child as women has a negative impact. Nowhere do I see those billboards on college campuses that say, ladies, until you've had your first child, your breasts are very vulnerable to alcohol as a carcinogen in your breast tissue. The whole thing with dairy makes me crazy, because I have found a million studies over the course of time. Almond milk is not dairy. Almond milk is milk that comes from almonds, and it's a beautiful substance. When we drink cow's milk, we are drinking the breast milk of another species. End of story. We know that there are many ways that the milk industry and lobbyists, I hope nobody's out in the hallway and going to take me out when I leave here, but we all know the Got Milk campaign was huge, because people looked at, and they all think that milk is a better source of calcium for your bones. Okay, not so. We all know that. So I don't suggest that we drink the milk of another species, their breast milk. It's for their young. It wasn't meant for us. And there are enough studies to show that there's increased risk of cancer from it, so I'm not a big fan of the milk stuff. Soy took it on the chin years ago. Isoflavones in soy, they are not endocrine disruptors. They don't alter estrogen levels, they don't alter thyroid function, and soy can be a wonderful alternative for protein. And a pooled analysis of 9,500 breast cancer survivors showed that a half a cup of soy a day actually had a positive benefit. And so when people ask me about soy, and I wouldn't be, pushing taking a soy supplement tablet as a benefit, but eating edamame, eating a protein source that comes from soy, it's absolutely fine. It's not going to hurt you. So this is the part of oncology and cancer care that we all deal with, or at least we should be dealing with, which is the side effects of the things that we prescribe. Our patients have to suck it up and get through our treatments. So if we can help them the best we can, we're doing a whole lot for them, because they're going to stay more compliant on the medicines that we prescribe and the treatments that we push. So glutamine, vitamin E, and omega-3 fatty acids all have been shown to help improve the peripheral neuropathy that can come from some of the medications that we give to save lives. Again, we need to avoid acetyl L-carnitine because it can worsen the peripheral neuropathy. But these are supplements that patients can take to be able to help mitigate those side effects. In addition, for $50 off of Amazon, your patients can buy ice gloves and ice socks that they can put in the freezer. I suggest 2 pairs because they got to get them through the process. I'm hoping that some of these cooling cap companies are going to start giving me 4 extra hoses so I can hook up the hands and feet at the same time. Because as bad as it is for someone to lose their hair, my nurse practitioner who had a triple-negative breast cancer, she now has such horrible peripheral neuropathy in her fingertips. It's the one thing that she said she wishes she knew, that she could potentially decrease the perpetual neuropathy that she has in her fingers, because she's also a guitar player. So she can't get that back. But we know that by applying the cool caps and the cool mittens and the cool feet, we can help our patients decrease peripheral neuropathy. Cold capping systems. I am so old that one of my best friends that I treated for breast cancer back in 2002 was treated with, she was part of the first cold capping experiment, which I told her she was crazy because it's kind of like putting your head in a freezer, and they only did 1 application, so she lost all her hair anyway. But now we know why you've got to cool before, you got to cool during, you got to cool after, and for all but the anthracyclines, a lot of patients can maintain their hair, and believe it or not, more women are worried about losing their hair than they are losing their breast, because it is the visible sign when they walk in a room that they have cancer. Radiation skin protection. Calendula comes from the leaves of the marigold extract. It is wonderful for avoiding radiation therapy issues to the skin. It's beautiful. For anyone that has grandkids or children, it also is phenomenal for diaper rash. I wish I knew about this when my kids were little, because it's a wonderful, wonderful soothing agent, and it has been proven to be effective for post-radiation skin issues. In 2012, my radiation oncologist, Bob Cardinelli, this is back when I was board certified in integrative medicine back then, and they all thought I was a little bit off the reservation. Bob comes running to tumor board. He's like, "Beth, you're not going to believe this. Ginseng has been shown to decrease radiation therapy fatigue by about 85%. I'm like, do tell. Like, I'd already read the study, but for my radiation oncologist to be running in to tell me that he had read this in his journal and he was very excited about it, let me know that I was definitely on the right path, because American ginseng not only helps with fatigue, it also helps with the radiation fatigue, but it also helps with general cancer fatigue. Important things to know about this. Ginseng derived from ethanol can have estrogenic properties. This is why you want your patients to take the one that is extracted from water, because it does not have any estrogenic properties. And that's why we call it American ginseng or Wisconsin ginseng. And it was also shown to just have general cancer fatigue. So not just in the radiation group, other studies, 115 studies have been done for general cancer fatigue. Ginseng, it's inexpensive, it's over the counter, and so it's something that can help us to help our patients. Nausea is another big issue. The acupressure bands actually have been shown to work, as well as acupuncture, and ginger and ginseng combined can also help with nausea. Hot flashes, they're horrible. If you've never had one, you don't know what it is. It's when you feel like you're having your personal heat wave. You want to rip off all your clothing, but it's unfortunate because you're in the subway and you're on your way to work, or you're making rounds in the hospital. Acupuncture significantly lowers hot flashes and improves quality of life. And it's a wonderful adjunct for us to be able to use in our patients. Black cohosh has been shown statistically to help with hot flashes as well, associated with aromatase inhibitors. I was asked out in Napa about clinical trials for black cohosh for men on Lupron. There are no clinical studies that have been done in that. It certainly isn't going to hurt them, and it has clearly been shown to decrease the number of hot flashes in women that we're dealing with them who are on aromatase inhibitors. So if you have a male patient who's getting Lupron and is having hot flashes, it's not going to do anything for the man boobs, which my dad hated on Lupron. He just said it was the worst thing in the world because he was not going to start wearing a bra at the age of 85. But the hot flashes were the thing that really got him the most, because it just made him feel like he was jumping out of his skin. We've got to remember our patients that we put on to anti-estrogen therapies, whether it's tamoxifen or aromatase inhibitor. We have created instant menopause in their vagina. It becomes the Sahara Desert. It becomes a place nobody wants to visit because it is too painful for our patients to even think about intercourse, and their daily discomfort. So lubricants are things that we use, that our patients can use for their daily personal care. Moisturizers, lubricants are what, moisturizers are for daily care. Lubricants are what they can use when they are wanting to be sexually active. I personally like Uberlube because it could also be used to get rid of the flyaways in your hair. So ladies, if you're going to pack one thing in your suitcase, take the Uberlube because it can be used for your vaginal dryness issues, and it also is sold as a hair defrizzer. As a surgeon, I'm always very concerned about my patients going into surgery. Patients like to take supplements. If we don't ask our patients what supplements they're taking, we won't know what they need to stop before surgery. So this is where this is a really important conversation. Garlic, ginkgo, St. John's wort, kava kava, ginseng, these are all supplements that need to be stopped prior to surgery for various reasons. Some have MAO inhibitor capabilities. Others help our platelets not stick together. Meditation is something that I'm a meditator I'm in process. I'm trying to get better at it every day. It decreases anxiety, depression, fatigue. It's a wonderful practice. Clearly, we should be doing it ourselves as the providers and recommending it for our patients. Most recently, I've started doing very intense breath work back in January of this year. It has been a phenomenal process for me. I have learned so much about it because there are clinical trials that show the benefit of breath work and how that breath work stimulates your vagus nerve and takes you out of fight or flight and into rest and digest. As a personal practice, as stressed out doctors that are at high risk for burnout, I highly recommend it. I have links on my website and stuff to the apps that I use. Sleep health is really important. We need to ask our patients how well they sleep, because we know that disrupted sleep puts people, particularly women, at higher risk for breast cancer. But we've got to also get rid of all those distractions, the ambient lights in the room. Don't be watching, shoot 'em, not rock 'em, sock 'em dead movies right before bed, because it's going to stimulate your central nervous system. And if we get good sleep, we lower our stress and we lower our inflammation. So magnesium works for sleep, melatonin, Somna sleep spray. There are so many studies out there that are looking at ways for us to improve our sleep health. Stimulation of the vagus nerve can help. I know I sleep better when I'm really being very on the ball with my breath work as well. So here's a little known fact that I didn't know until, okay, full disclosure, I got trained in psychedelic therapy over the last 2 years, not because I wanted it to be legalized for recreation, because I absolutely do not. I am not a fan of that. But in our cancer patients, antidepressants do not work. SSRIs do not work because what we see as possibly as depression actually is an existential crisis of the fear of death. And so antidepressants don't work in cancer patients. So when patients go through SSRIs and multiple drugs and they're still not feeling better, we need to realize that it's the same as a placebo. It's not working. That is what pushed me into a space of looking for, what do we do for depression and anxiety in our patients? Well, exercise helps with depression. Melatonin can help with the sleep, as well as the magnesium. Gelsenium is a homeopathic that's actually been able to help improve anxiety. It's also what in the House of Cards, it's what the president's wife in the House of Cards used to murder her boyfriend, but she overdosed him in it, so it's not going to happen to anybody here. And vagus nerve stimulation is something that I'm working very heavily in the other aspect of my life, because it helps us to be able to deal with the anxiety. But psychedelic therapy research in cancer, that's like my next chapter. That's going to be the final chapter of the Beth Dupree Survivorship Handbook for Cancer Patients. This is the study that absolutely garnered my attention after I read the book, How to Change Your Mind. Bill Richards and Roland Griffiths, amazing, amazing guys, looked at single-dose psilocybin, and psilocybin is a magic mushroom. I didn't even know that psilocybin was a magic mushroom, nor did I know how to spell it in 2019, because I was raised during the Nancy Reagan, this is your brain on drugs era of the 2 eggs in the frying pan. So this is a really huge departure for this very conservative soul. What they showed was that they decreased depression and anxiety by 78% and 83% respective. That doesn't happen with a drug. And it was one dose, appropriate set and setting with the appropriate integration. 6 months later, these people were still really, really good. 85% said it was in the top 3 most impactful experiences of their life. 65% said it was the most impactful experience of their life. This is the world of oncology care that I believe that, you know, when I'm dead and gone and your grandchildren are doing whatever they're doing, if for anything, this is what I'm going to become known for, because we need to bring this into our traditional Western medical care. Stephen Ross, out of NYU, wrote a really good paper looking at all the clinical trials, 10 trials, 445 patients, and they found 6 open-label trials. They showed that psychedelic-assisted therapy produces rapid, robust, sustained improvements in cancer-related psychological distress and existential cancer. He's about to do another study with LSD right now on early-stage cancer patients, because most of these studies were done in late-stage cancer patients. So imagine if we were able to do this after our patients were done doing their Western medical treatment, and then we gave them the opportunity to have that inner reset where they're no longer living waiting for their cancer to recur. Imagine that world that our patients can live in. Currently, ketamine is our one legal entheogen we can use. It's wonderful for pain management. It hits the NMDA receptor, so we can decrease the amount of narcotics our patients are getting at the end of life. So instead of putting somebody on a shit ton of morphine, which gorks them out, takes them away from their families, takes away their ability to be present with them, you give them ketamine, you're able to treat the pain and allow them to be present with their families. We can make our transitional care completely different. So this is why you ask your patients about the supplements they're on. This is Jane. She was 7 years out of bilateral stage 3C invasive lobular carcinoma, neoadjuvant chemo, 30 nodes out of 30 nodes on one side, 27 out of 27 on the other side, all positive, which basically shows us that she probably had a very long-standing luminal lake cancer. She got a complication from she bought horse chestnut off the internet for her varicose veins. Started taking a supplement. Unfortunately, it whacked her liver after all the chemo she had had. And she ended up dying after a chest tube was inserted to try to take the fluid off her lungs, because the radiation had made her vessel stiff, and she died as a result of that injury. And it came from a supplement. Now, had she told me she was taking horse chestnut, I would have had to Google it and research it and find it. But the point is, our patients need to be honest with us, and we need to be open with our patients. So the ultimate goal is treating disease is the same as healing. Healing and curing, sometimes they occur together. All of our patients have the capacity to heal. We may not be able to cure every patient, but that doesn't make us failures as physicians. That makes us, you know, spiritual beings in the most human experience of all, which is we're providing care for our patients and being there with them on this journey and being able to be there as their partners in care It allows us to have fulfilled careers. These are some of the books that I read and the resources which you'll have, and you can find me all over the place, and thank you. I literally walked out of my cancer center, and that car was parked out front, and I'm like, I wanted to know whose car it was, but like I don't have I couldn't like put their license plate through the DMV, but I was thinking that would be a pretty good gift for any cancer surgeon. So, any questions? Yes.
Are you finding anything in preventative care, especially for someone with a germline mutation, that they know they have a germline mutation that hasn't been activated?
So when we look at all the data, and I wish that there were more studies on this. I have a lot of patients that older patients that had mutations that we didn't know until they came through the next second and third generation. Lifestyle is our best defense is still the offense of good sleep, good nutrition, normal BMI, decreased stress. And the studies and the data is out there. When we look at risk reduction of more cancers, future cancers as well, it's all those factors. It's not about taking a specific supplement. It's about looking at the totality of the soil that seed, that DNA could potentially be in, and trying to avoid the initiators.